So obviously we need a good indication. So in terms of the fact that the patient qualifies for the device, we then do a number of screening ECGs and comparing specially developed templates to see whether the patient is suitable for the device. And this is done with the patient, kind of lying down, being static, and also dynamic during a walking test as well, to say, well, the patient is then, let's say, someone we can use and somewhat appropriate for the device. Thereafter, we've got the diagnosis, the decision is to implant a defibrillator. I then will decide on whether a transvenous system or a subcutaneous system will be the most appropriate one. In this case, we thought that the subcutaneous one was good. The patient is very young, the patient is extremely active, so he's going to require for the defibrillator to be in for a long time. We know the transvenous leads, there is certainly a degree of attrition of the leads over time because of friction and wear and tear, and so one can end up with lead failure. Infection is always an issue, so having to extract these particular leads in young patients can be potentially hazardous and lethal, in fact. And then the device has distinct advantages to me. It doesn't make any contact with the venous system, so infection is therefore not a problem. There's no risk for any cardiac injury or lung injury, for example, a pneumothorax, which is a bit of air around the lung due to inadvertent puncturing of the lung while we're trying to get the traditional leads in. There is also no evidence of chronic, long, ongoing fatigue of these leads, but time will obviously tell because they're relatively new. But none of these have been described with the subcutaneous ICD, and so I'm extremely encouraged by this technology. So I think patients in particular who have polymorphic ventricular tachycardia, which is a rhythm which is extremely difficult to have anti-tachy pacing for. So patients requiring anti-tachy pacing, which is where the pacemaker itself is trying to overdrive pace the patient's rhythm, I don't think are that suitable. Patients who require bradycardia pacing, because the device is not able to also act as a pacemaker itself. It is able to present the patient with some what we call post-shock pacing immediately after the device is discharged, but this is not adequate for someone who's got a conduction abnormality. So conduction abnormalities and needing a pacemaker, patients who definitely will benefit from anti-tachycardia pacing, I think those patients are not going to be as suitable, So if you don't fulfill those, anti-tachycardia pacing is not required, you have normal conduction system, brady pacing is not required, and we have a young patient, and in particular those patients where they have underlying channelopathies such as long QT syndromes or potentially Brugada syndrome, where there's an abnormality with the ion channels, and as a consequence these electrolyte disturbances involved in the pumps within the heart cell become defective, causing the arrhythmia. So the younger primary prevention patient not requiring anti-tachy pacing, not requiring bradycardia pacing, this device would be very suitable. In particular, the fact that the device is going to be in for a long period of time. And the nice thing to me as someone who has to extract infected leads all the time is that, if there were any related infection or subcutaneously to the device, well, one can just then pull it out from underneath the skin. And this is absolutely safe for the patient. So I think that the benefits are marked from that point of view, because there's a very distinct morbidity and mortality associated with transvenous systems. Correct, yes, and he was subsequently resuscitated at the roadside after he'd fallen from his bicycle, and it was fortunate that they had actually kept the rhythm strips as well from that occasion, confirming that he had polymorphic ventricular tachycardia. And we've done an extensive workup on him, including cardiac MRIs and biopsies of the heart, and we are planning also just to await the results of his genetic testing. But in someone who's already had such an episode, the device is actually now secondary prevention, because he's actually had aborted cardiac arrest. He's also unfortunately started to develop new symptoms with regards palpitations and lightheadedness, and this is very concerning to us. And so as a consequence, we've decided to get the device in as soon as possible.